Assalamu alaikum, everyone. This is Dr. Rizwan Hassan. We are going to start the webinar series in about 10 minutes. So please, all are requested to join. Thank you. Assalamu alaikum, everyone. I'm Dr. Rizwan Hassan. I'll be your host tonight. Welcome to the second edition of PDA Karachi webinar series. After successful of our inaugural session, and we are back with another exciting topic. We will begin in about 10 minutes. Please keep your phones, mic and camera muted during the session. Use the chat box for any questions or technical issues. And I have shared a Zoom link. Okay, you can share it with your colleagues who might benefit it. Also, please note that only 100 participants are allowed. So your participants are requested to join early. We will be beginning it soon, inshallah, after 10 minutes. Thank you. Bismillahirrahmanirrahim. Assalamu alaikum and a very good evening to all participants. Once again, I am Dr. Arshad Hassan and it is my pleasure to host you all tonight. This is our second webinar of our PDA Karachi Weekend Webinar Series, designed to bring valuable clinical learning to your screens every weekend. Thank you for joining us on a Sunday evening. We are about to begin a very relevant and practical topic. To begin this evening on a blessed note, I would like to invite Shariar, a student from LCMD, for the recitation of Holy Quran. Over to you,
أعوذ
Shariar.
بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت ربنا لا تؤاخذنا إن نسينا أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين صدق الله العظيم.
Jazakallah khair for the beautiful recitation. Tonight's topic is Class 2 Composite Restoration Made Easy, something every dentist and student faces regularly in a clinical practice. We are honored to have Professor Dr. Arshad Hassan, HOD of Operative Dentistry and Endodontics at Daw Dental College, Daw University of Health Sciences, who is renowned for his ability to simplify procedures and share practical insights. Before we begin, a few quick announcements for smooth participation. Please keep your mic and camera off during the session. We will be having a Q&A session at the end. Write your questions in the chat box anytime. Our YouTube live link will be shared here for those who couldn't join or wish to watch later. At the end, we will be sharing a feedback form link. Please take a minute to fill this out. And if you are facing any issues, audio or video, write in the chat box. Our team will assist. Without further delay, let's get started. Sir, the floor is yours. Over to you, sir. Thank you.
Bismillah Rahman Rahim. Thank you very much for an excellent introduction. Thank you very much. Allah Ta'ala is great. So let us start today's presentation without any further delay. Please let me know if I'm audible to all of you. Is my voice audible? Hello? Just type in the chat box. Is my voice audible?
Yes, sir, it's audible. Everyone is
Yes.
giving thumbs up.
Okay, can you please keep your mic on so that we can have at least some, if there are any issues, I can communicate with you. Dr. Saab? Okay, so
my mic is on and participants can chat if they have any query or concerns.
yes,
I will be reading. Say sir.
Indeed. So I'll share my screen now. And this is my presentation and it's always be ready to go. Okay. So we start with the name of Allah Almighty. And as I've already been introduced by the host, Dr. Shahryar. So this particular webinar is a rerun of a previous webinar that was held with the help of PDA Lahore. And I basically don't like repeating topics, but this is such an important topic that affects everyone from a student, especially the final students, to recent graduates, to the more senior ones. So this is it is my belief that class 2 composites are at times more difficult to perform than even the endodontic procedures because of night eye rotaries, the an endodontic procedure of a routine molar or perhaps a premolar or incisor or canine. Any tooth you talk about with a moderate curvature and a good mouth opening of the patient and a patient who's cooperative, and if the isolation can be maintained rather easily, that procedure has become quite easy. But the class 2 restorations remain a difficult area, and especially because our patient reports so late and caries have extended so much deep gingival at times that restoring these lesions becomes a challenge. So this is the today's webinar announcement, which is exactly similar to the one that I had with the PDA Lahore. Thank you very much for joining, all of you. I can see a good number. I can probably see my few of my students as well. So this is my introduction, which has already been introduced by the host. So let me move on. Okay. So as far as the longevity of these restoration is concerned, this basic slide and a few other slides are really from my final year lecture. But the problem with this topic is that those slides are so integral to today's topic that I've included them as they are. So as far as the longevity concerns are there, and people talk about that whether the white fillings are as good as the amalgam ones. So research, and this research is quite old. And I was looking into some new papers, and I couldn't come up with something new. And everything points out to the same three statements, that it is equal to amalgam and cast gold, performs as well as amalgam up to 10 years, and these results are for the older composites. So what about the newer ones? Of course, as the newer ones are becoming available in the market, they're becoming better and better. And these few radiographs show my cases that have a follow-up of up to 7 years or more. And again, the funny thing is that even these radiographs are more than perhaps 5 to 7 years old. So if I were to review these patients one more time today, so these restorations would be more than 15 years old, maybe for some even 20 years old. And all of these class 2 restorations in all of these patients, three radiographs, these three separate patients. However, there are some contraindications as far as restorations are concerned, and in general, and composites in particular. For example, if you have an extensive restoration, I was looking at the data today, and even today with today's composites, if you are going for an extensive restoration, for example, a complex restoration, which might be replacing one of the casts, even today, the composites are perhaps good enough or not good enough, but still there are concerns about their longevity. So perhaps as an interim restoration, maybe until such time that patient makes up his or her mind, a composite can be a good alternate to amalgam or some other direct restoration. And large restorations in patients with significant parafunction. These are the patients in which you'll have loss of restorations, even if it's not a large one. Even small restorations can be lost, especially if the centric contacts are concentrated on that particular restoration. For example, I give an example. You have a patient who's missing all molars on one side, and that patient has a premolar, which is a terminal tooth, and there is a class 2, let's say distal class 2. That distal class 2 in such a patient with bruxism is bound to fail, because most of the load of that patient in centric occlusion and in dynamic occlusion will be on that particular tooth and that restoration. So that restoration might fail. So you have to, decide on patient to patient basis in which patient you are going to do a direct restoration, and in what you might suggest the patient that let's go for an indirect one, especially, if a restoration is lost twice, no matter how well you have done it, you have taken all the precautions, and if that patient loses that restoration twice, maybe because of the size of the restoration or perhaps due to the presence of bruxism, so that can automatically become an indication for an indirect restoration. And then a patient with high risk or a patient is non-compliant. Of course, in non-compliant patient, he or she may not be able to keep his or her mouth open or is claustrophobic. So you're unable to place the rubber dam, etc., etc. So whenever you are unable to have a good moisture control, number one, and number two, if the patient cannot keep his or her mouth open for a long enough time for you to do restoration, that filling is bound to fail, because we all know that white fillings are very sensitive to moisture contamination. And then a high-risk patient, for example, I gave you a very extreme example of a Sjogren's syndrome patient in which there is a xerostomia and is unable to keep his hair or mouth clean, perhaps, and keep the decay away. The cleaning is not a problem, but lack of saliva, which contains a lot of antimicrobial agents and washes away a lot of the bacteria away as well, is not there. So in absence of these antimicrobial agents in the saliva, a high caries risk patient may have problems, and it's again a relative contraindication. If a patient can maintain his or her mouth clean enough, can come for routine fluoride application, then composites have no problems. And I forgot to include one of the slides in which one of my patient who is a Sjogren's syndrome patient comes to me for follow-ups every year, and those restorations, the composite restoration in class 5 situations are holding quite well. And then, of course, unable to obtain adequate affiliation. I've already covered this point in my presentation. Let's move on. Okay, so one of the big problems with composite is bonding at gingival margin. So if you look at this smaller lesion to your right, this smaller lesion can be, restored and perhaps and first or foremost isolated with the help of a rubber dam very easily, no problems. And then when you remove the carious lesion, the gingival margin will have some sort of enamel. Let me just bring my what do you call the laser pointer so that I can show you what I'm trying to tell. Just hold on a second. Let me get hold of the laser pointer. Well, let's see. Okay. From where can I get the laser pointer? Okay, forget the laser. Let's forget the laser pointer for a while. I think I got it. Yes. Okay. So let me go back. So over here, you can see a bit of enamel that is left at the gingival margin. The problem really is with the larger restorations, where when you remove all the carious lesion, you may not be left with any enamel at the gingival margin. So you won't have enamel on all the sides of that restoration. And this gingival margin will be devoid of enamel. And we all know that bonding with dentine, especially the root dentine, is not as good. However, in recent days, in recent years, in recent era, the bonding agents of the contemporary bonding agents are good enough to achieve a very good bonding. So what we can do over here is, if somehow you can have this situation where you remove all the caries and leave sound enamel. By sound enamel, I mean that enamel that is not demineralized. If the enamel over here is demineralized, you'll have to remove it, because demineralized enamel will not bond to composite, and I'll explain later why. So this can be a situation, and such an enamel has been called an internally beveled enamel as opposed to the externally beveled. When we place bevels for our restorations, let's say there is a class 4 restoration and we bevel all the margins of that restoration to enhance the bonding and as well as to camouflage and for a chameleon effect. So this is essentially an internally beveled enamel, a lip of enamel that you will not hack away for a composite. For an amalgam, you will probably have a flat floor like this situation. And if there are enamel margins, you'll have to bevel them so that they don't break. But for composite, you have to have certain situation in which like you need to preserve enamel if you can, if they are not demineralized. And we'll see in the video as well. I have a video demonstration for you as well. So we'll move on. So the kind of liners that you can use beneath a composite is probably a lot of people might be still be using calcium hydroxide. I don't use any liner. I just use a flowable, a bulk fill flowable composite. I don't even use RMGHC. I think maybe 0.001% of cases I might have used a sandwich technique, but my tube go material is a bulk fill flowable, and we'll shortly see in a video how I use it as a liner, and then I restore the rest of the restoration. So one of the most important part of your restoration is your matrix band. And if you can see on the right, I have this a big set of armamentarium where the different types of matrix retainers that I have added to my practice over the period of years. For example, there is a circumferential matrix band. These two both are circumferential ones. Then this is a sectional one, and this one is in use. If you can be seen here in this picture, it is an excellent band for restoring the distal sides. And if you have isolated the tooth in such a way that the retainer is on the tooth, that has to be like restored. So this is an excellent retainer in that situation. And then these are the palodent ones by the Polydentia. And these are quick matte slabs made of titanium, very thin titanium, and very flexible and excellent, gives excellent contour. And these are the DME bands. And then these are your ordinary Toffelmeier ones. And this one is again a Toffelmeier in a disposable situation with a plastic retainer. And this is a Toffelmeier band, of course. Now these rings, these are the Bytine rings that help us in so many ways. For example, for a pre-wedging effect, from a pre-wedging effect to that keeps the band in place and prevents any flash. These rings are extremely important, and you need to add different kind of rings, because different rings are used in different situations. For example, this is an ordinary ring, but this is the Polydentius my clip, and it's very usable kind of a ring in certain situations where these two cannot go. And then these two by Garrison are excellent rings, and you really need to spend on your armamentarium. Only one of these rings is 50,000 rupees, so very expensive equipment, but you have to add to your armamentarium. And then a recent innovation that I found on the net was this retainer and band assembly that really caught my eye. This is one of the quick connect, and this is a very ingenious innovation. And let's have a look at the video of how to use. Can you see these tags on the band? And they have a very unique kind of use. Let's see a video. I don't have it, but I saw it on the internet, so I thought I should share it with you. So if you look at it, you can hold the tags against the adjacent tooth, and it will give you a very good contact. So let's see a video. If I can play it. Let's see if this can be played. Yes. Okay. So this carrier connects to this holder, and then when you rotate it, the size of this matrix band reduces. And then there are two types of matrix bands, one without tags and one with tags. So just put it on the tooth and remove it. So the weight of the retainer will not dislodge the retainer, will not dislodge the Toffelmeier rather. So you can put the wedges, you have to put the wedges, and then you can hold these tags against the adjacent tooth, or you can bond it to the adjacent tooth. And then what will happen is that it will keep the band in such a shape that you will be able to, do your restoration. Because if you don't hold the band away from the this tooth and towards the adjacent tooth, you'll have under controlled restoration. And this is one of the reasons why you have open contacts. So of course, open contact is one of the biggest problem with the composite. So this is the other way is you can hold it towards the adjacent tooth with the help of a probe. Keep your pressure on the probe and then cure it, and you'll have an excellent contact. So this is an excellent innovation. I think let's wait for China to copy it, and then we can all buy it from AliExpress. So one of the techniques that I use during my restoration is a Snowplough technique. All of you know, but just for the sake of description, what you do is in any restoration, it is not limited to class 2s. Just place some flowable composite, don't cure it, then put your packable or restorative composite over it and then condense it. So when you do that, the flowable composite, by the virtue of the pressure on the packable composite, would get into all the nooks and crannies, and it will flow into all the gaps, and then just cure the thing in one go. And then you will get a very good adaptation of your composite to the base of the cavity, because that's one of the big problems where you have gaps in highly used to have gaps in highly packable composites. So you can avoid that with your regular ordinary filling the restorative composite if you just use one or two drops, and you will see it in the video as well. So these are the finishing and polishing equipment and things that I use for finishing, polishing, restorations. My go-to burrs are these by Shofu, and these are in two colors, gray and white. Gray is for gloss finishing, and the white one is the polishing. Then you have soft flex strips, soft flex discs, and these are the other things that I use. Also use, I rely heavily on these burrs that you can see on this picture. You will see it in a better way in the video. These are the flame shaped burrs. One is the needle and two are flames. The red and yellow coated yellow banded burrs from Money, and these are excellent burrs for a lot of things, and you'll see how to use them. So the restoration of proximal surface starts with its diagnosis, and one of the best tools to diagnose even the incipient ones is bite wing radiograph, and you have to have your technique properly in place and with the proper equipment. Otherwise, you will not be able to diagnose a lot of, and you'll miss a lot of proximal decays, and your patient will come back and say, डॉक्टर साहब आपने तो मुझे बताया नहीं कि मेरे ये भी था. तो कैसे बताएंगे जब आपको खुद नहीं पता चलेगा, तो आप कैसे बताएंगे? So a best way to know is have to have an excellent bite wing radiographic equipment and have a good sensor with you. I'm sure all of you are using digital sensors. They have become so cheap nowadays. Lakh, sawa lakh, 1.5 lakh ke ho gaye ab to, that I'm sure everyone has one. Use them, utilize them in a proper way, and then they can become one of the best tools to help your patient and help yourself as well, so that the patient does not blame you for not telling him or her about all the restorations that he had and the other dentist told them and you missed them. So what you need is this cone indicating device. The one that is on the left is one of these devices made by Indus Bello Company of Brazil. It is probably not available in Pakistan, or probably it is. Maybe you'll have to ask your suppliers, or you can use any other sort of the cone indicating device that you can get hold of. So the way to use is to place this part of the device first, and then fix this cone indicating device. So one of the important things for you to know is the plane of occlusion of the teeth, for upper teeth especially. So you need to place your sensor parallel to these, because you want to open up the contacts. When the rays come from this side, they will strike the film over here, and you need to have the contacts open so that you can properly diagnose the proximal decay. If the rays come like this, in this direction, there will be a lot of overlap, and you will not be able to see the proximal decay. So this is the proper way of placing it, and then what you do is, the slide is not moving. Okay, so this is the arrow shows the direction or the position of the X-ray film, and then what you need to do is you need to open a patient's mouth, observe where the occlusal plane is, and then place your film parallel to the occlusal plane, and then ask the patient to bite like this, and then you can take the X-ray. So now let's see a small video about this technique. So I am placing the first part of the cone indicating device that will hold the cone indicator. It is in place. Now I will bend over and look directly into the patient's mouth. I'll ask the patient to move his or her mouth up. I'll ask the patient to open the mouth wide, and so that I can see the occlusal plane. Then I'll place it parallel to the occlusal plane. And then I'll ask the patient to close his or her mouth, and then my X-ray beam is there, X-ray cone is there, and I'll expose, and here is the X-ray in which you will be able to see the contacts have been opened, and this is the way to take the radiograph. And this is one of the radiographs taken with the help of that technique, and you will be able to observe anything. For example, here you can see an incipient lesion that is extending perhaps into the dentine, but it's still quite an early lesion. You can perhaps decide to observe it and ask the patient to come back after 6 months, and if it progresses even further in size, you have to restore it. But the text says that if it is into dentine already and it is spread into dentine, you have to restore it. So, and a lesion as small as this can be viewed, and you can of course zoom in and observe properly, and then you can also see the margin of the existing restoration, be it a crown or a restoration or anything, or any early demineralization in the enamel like this. So what else you can do is you can self-critique your own work. For example, if you look at this slide on your left, is a preoperative bite-wing radiograph. This restoration was loose and dislodged. There was a lot of secondary decay around it, so this was restored properly. And then on the middle one, you can see two proximal lesions here, and this is in early stage, because you can see over here it has been restored, but you can see that this lesion is still in enamel, and I have decided, and perhaps a little bit in dentine, but I've decided to observe it, and if this lesion progresses, I will definitely restore it. And then you can see over here as well, enamel lesion and going into the dentine, and one over here, 2 lesions in this patient, both of these restored, and then you can keep following these patients. And please observe one thing, that I was able to preserve enamel over here, and this is internally beveled enamel here, internally beveled enamel here, a little bit of here, but lost it over here because, of course, of the carious lesion. So the next important topic to discuss is the bond durability and how it gets degraded, because long-term bond durability is very important for the longevity of composite restorations as opposed to amalgam. So the problem with amalgam is that, the problem with composite is you have to protect the interface between the adhesive and dentine. And how will you do it is by making sure that you do not denature the collagen. And because of the denaturation of the collagen, either at the time of bonding or later on because of release of matrix metalloproteinases, because probably you have etched the enamel very strongly, the bond will degrade and you'll have recurrent decay. And because of the denaturation of enamel, of collagen, and a very aggressive etching technique, you can have release of MMPs, the matrix proteinases that denature the collagen. So the ways of taking care of this problem and having a durable bond is either to have a bonding agent that has a reduced content, and water is required for especially the self-etching and 7th generation agents to complete its reaction. But too much water can lead to the hydrolysis of the bond. So what you need is water in exact amount. So the manufacturers have come up with newer bonds that have reduced water content, or perhaps you can add, they can probably have added more amount of hydrophobic monomers. So basically these hydrophobic monomers help in converting the state of hydrophilicity to hydrophobicity. Basically they are bifunctional monomers. I am sure all of you know about it, how the monomers work. And then you can have certain fillers in your bond, and at the same time you can have certain antimicrobial components. For example, you can probably use chlorhexidine to offset the effect of MMPs, or perhaps you can probably use glutaraldehyde for better cross-linking. Let's move on. So my strategy to enhance bond durability is very simple. What I do is I don't etch my dentine, because if I etch dentine, you'll have release of MMPs and a poor bond durability. I use a 7th generation one bottle etch and dry technique, in which what I first do is I use the etchant to etch the enamel only So I will put my etchant only on the enamel, and then I will use a I will of course wash it and dry it. Then I'll use a 7th generation bonding agent that I'll apply on the dentine and of course the enamel as well. I'll apply one coat. I'll keep agitating the bond with the help of my micro brush for at least 20 seconds, and then I will blow air a little bit to evaporate the solvent, and then apply my second coat, and then again I'll keep using my micro brush. I'll keep agitating the bond. I'll keep rubbing it on the dentine for another 20 seconds, and then I will again blow some air to evaporate the solvent, and then I light cure it. So this is how I do my bonding, and this technique refinement has really helped, and I have a very few, rather next to none, episodes of uh, sensitivity after restorations. Another important point is the light that you use. So if you're using very cheap Chinese lights, trust me, they are doing nothing for you. Rather, if you have post-op sensitivity, this might be one of the reasons why your patient is having post-op sensitivity. Because the reason is that the companies that were making the bonds few years back, they have changed their photo initiator. They used to have camphorquinone as photo initiator, but the problem with that was that it was causing yellow discoloration in composites. So they have come up with certain different photo initiators. Now, the problem with those photo initiators is that they are not within the curing range of ordinary light. Yes, that's the problem. If you can see over this at this graph, you can see that the curing ability of this particular light, this is curing pen by 8 teeth. So it starts from 385 and it extends till even more than 500. So that is the thing that we need nowadays. We need the curing lights that are multi-wave, multi-peak, and poly-wave. They have different kind of LEDs. This particular light has 4 LEDs in it. So if you are using this kind of a light, you are going to make sure that you are able to cure the current generation of photo initiators as well. Otherwise, your composite will not be cured, and you will have an illusion of curing, but your composite will not cure. So I can see a lot of activity in the chat box. I hope there are nothing immediate questions to ask. I'll move on. So after this slide, we'll move on to the video demonstration. So important steps in cavity prep. One of the most important steps is that you need to remove demineralized, weakened carious enamel that appears as white and frosty. We are not going to do any justice because maybe someone has a wrong concept of minimally invasive dentistry, that they are going to preserve that white enamel. That white enamel may be left on a smooth surface, but not at the margin of a cavity, because your bond and your composite will not bond to that white chalky enamel. Reason is because there isn't any structure left. It is demineralized enamel already. It doesn't have any strength in it to withstand the bonding forces. So you need to have a sound peripheral enamel margin to which adhesive restorative material can bond and seal. And histologically, and this line is from this particular book, the Avijit Banerjee is a champion and a master of minimally invasive dentistry. So I take these words from his book, that histologically the optimal peripheral seal will be at the interface between adhesive restorative material, and the best seal will be with sound enamel. And in reducing kind of a trend, you can see the direction of the arrow, then with sound dentine. So the best bond is with the sound enamel. Next is dentine. These will provide you best bond. Number 1 is enamel, sound enamel. Number 2 is sound dentine. Then caries affected dentine. Last is the caries infected dentine and carious enamel, to which you will have no bond. So it's better to avoid those. You may have certain caries affected dentine, but not at the periphery, please. Mind it, please. In the center, you can. Maybe on top of the pulp, if you're afraid of exposure, you can leave a bit of caries of affected dentine, but not infected dentine. So let's move on our first case. This particular case is a clinical case of a proximal restoration in patient's the right side of the patient, right upper second premolar, the distal surface. The patient, we were able to diagnose this case lesion on a routine investigation, on a routine visit, in which the patient asked for checkup. A bite wing was taken, and you can probably see almost every contacts have been opened up so that you can see if there is any caries lesion or not. And this was spotted as penetrating in quite a lot of distance into the dentine, and this can be described as a moderately deep or perhaps a deep restoration, not a very deep but a deep restoration, because it's into the into the third of dentine, perhaps 2/3 of the dentine, and perhaps quite near to the pulp. So let us have a look at the video. I'll stop sharing here. And I hope these questions are okay. There are no questions at the moment. Fine. I was just looking at the chat box. So, okay, let me move on. And I will just start my video. And I'll share my screen again. So, this is an unedited video. I have not edited it. So, let me just increase the speed so that we can complete it in a less amount of time. Right. Double. Okay, no, normal size. We are just speed. Playback. Okay, playback speed. Okay. So I'm going to increase the playback speed to perhaps 2 times. There you go. Yeah. Okay, I'll share it again. Okay. So I hope this screen can be seen by every one of you. And let me maximize. I'll try to maximize my screen if at all I can. There you go. This is maximized. Okay. So I hope every one of you can see the screen. Is it visible to all of you?
Yes, sir, it is visible.
Thank you very much. Okay, so let me start this presentation, this video, and I'm again going to need my laser pointer to let me see if I can get hold of it from wherever I did last time. Okay, let's see. Let's see. I don't know where I got it from last time, honestly speaking. Okay. Well. Not here. Not here. Okay, can you please help me with the laser pointer? Bottom left side. Okay. Thank you. No, it's not there. Oops. Okay. Let me see if I can minimize this screen and look for the laser pointer somewhere. No. The question and answers will be at the end. Okay, let me just continue with the presentation. Let's just forget about the laser pointer for a while. Okay, so this is an unedited version of this video. I have not edited it, so you'll see the action in real time. Not real time, of course. The video is speed it up to 2 times. So you can see this proximal lesion over here. Can you see the arrow? Can you see this arrow that I'm using? Okay, no answer. Yeah, okay, the arrow can be seen. Okay, fine. So let me play this video. Okay, so I'm starting with in my initial penetration into the enamel with the help of a round bar. You can use a Fisher bar as well, and that's what I've done. I've gone onto a Fisher bar. I'm using it in a 2 pro movement, and my mirror is getting all wet. So my assistant is cleaning it. I have gone already into the lesion. So what I'll do is I'll keep going apically at this moment, just an apical to and fro movement, so that once I reach the bulk of the restoration, bulk of the lesion, then I'll start to develop my outline form. I can see the carious enamel, carious dentine, and I can see the lateral spread of the caries, and that is what I'm going to do. I'm going to attack that lateral spread right now. That's what I'm doing. I can see this caries over here. This enamel is intact right now because I want to protect the adjacent tooth. So this enamel on the proximal surface is intact. So I'm using my burr. I'm going proximally, buccally and lingually, buccally and palatally. I'm trying to clear the lateral spread of caries, and that when I clear the lateral spread of caries from the dentine enamel junction, I'll have my outline form. Now I have fractured the remaining enamel wall that was there, so that I can have a better sense of the lesion. There is a lot of caries still left, so I'm going to dry it, and perhaps I'm going to use my slow speed, because whenever I dry it, I use my slow speed. So let's see if I'm going to use it or not. So what I'm doing right now is I'm putting a wedge, and that wedge is placed so that I can protect my rubber dam septum and at this area, because if the cavity goes a little bit subgingival, my burr and my instruments can damage the rubber dam, and I can have a leakage from that part. So I'm not happy with my wedge placement. I've removed it. There is a bit of bleeding, no problem. Once you place it back and wash that area, wash and dry, all the bleeding will be gone. Nothing to worry about. Don't worry about this little bit of bleeding. So let's move on. I'm again continuing with my high-speed handpiece at this moment, because I can see over here, I can see a lot of caries. Can you see? Can you all of you see this? This is the palatal wall. This is the buccal wall. This is the spread of caries along the dentino-enamel junction as well as in the dentine. So, and this is the white chalky enamel I was talking about. So, I'll continue to extend my cavity until I have the margins of my restoration are all sound. There is no caries. This is infected caries. Just look at the color. Remember this color. It is caramel colored. All of you eat caramel ice cream. So I'm going to spoil that moment for you, because every time you eat caramel ice cream, you'll remember this the soft dentine, infected dentine rather. So I'll continue using my high speed and extend the outline form, and this is what I'm doing. And now I'm switching to a round burr in a slow speed handpiece. Of course, it is used without water spray, and I'm going to try and remove all the decay with the help of a slow speed. So this is going to be the sequence. First, the high speed to attain or achieve an outline, then a slow speed to remove caries, and then an excavator to further remove any remaining caries. Let's move on. Let's move on. And then I've dried it again, washed and dried. Oops. Wait a second. This chat box has opened. Okay, so I'll continue removing the soft carious lesion, as you can see over here. And let's move it on, because there's quite a bit of video remaining. And I'm now checking with the help of my probe about the feel of the caries only in this area, because I want to know if I remove enough caries or not. If it feels sticky, that means caries has not been removed. That's it. Nothing special about it. So I'll continue removing the soft dentine, carious dentine with the help of my slow speed round burr. this will continue, and then I need to now extend my outline a little bit because I'm not happy with my outline at the moment. So I'll continue extending my outline. At this moment, I am basically moving in this direction. This wall has carious dentine, but I'm not going to extend my high speed all the way to the gingival floor. So important point that I would like to make here is that I'm only using it on the enamel and perhaps a little bit of dentine, because if I take my burr down, I might, expose the pulp. So, and because high speed is so fast, and I may not have control over it, especially if someone is not using a microscope. Of course, this video has been made under a microscope. So I'm just removing enamel from here, nothing else. Oops, minimized. Okay, let's move on. So this is continuing. Now what we have is, if you can see this thin lip of enamel, and this is still a little bit at right angles to the external surface, but this is not. So a little bit into the video, after some time, you will see me removing this with the help of the red flame shade burr. So a little bit more of outline. Let me move it forwards. Let me move it forwards further. Okay, so now you can see a little bit of sound enamel over there. Not exactly sound, but still you can see that this area is now becoming clean. But still you have this caramel color, and caramel color is infected dentine. So I'm using a small excavator to remove it. We'll keep removing it. Now this one is a larger excavator, and this is a very sharp excavator. Can you see this wide area here? It has been achieved only with the help of slow speed handpiece and an excavator. And this is what you want to have, not this. This is carious and this is sound. Now you can really appreciate the color difference. Let's move on. Okay. I'll keep on removing it. Until such time that we have removed all the carious dentine, and I'm again extending my outline. Okay, so I just want to take you a little bit back. So now I'm going to use my red banded flame burr to refine the margins, because this is an unsupported enamel prisms over here. We don't want to leave these enamel prisms here, because under the force of occlusion, these enamel prisms will break here and here. So I'm using a red flame shape burr. You can see the use of the red flame shape burr. And I'm straightening my walls as well as removing any unsupported enamel prisms on the palatal wall as well as on the buccal wall. And you have to be very careful not to nick the adjacent tooth. If you don't have good hand control, please use a metal band over here. Place a piece of metal band and then do this thing if you cannot control your hand very nicely. And then now if you look at these walls, the buccal wall and the palatal wall, it is now meeting the external tooth surface at somewhat right angles. Also, you need to break the contact in class 2s. You know why? Because if you don't break the contact, your matrix band, the very thin matrix band, the palodents or the sectional bands will not go in. And if you manage to put it in, no matter what you do, you will only have a tight contact from the place where you have not opened the contact. And from the place you have opened the contact, you will have a loose contact. So the contact, the recreation of contact will be very poor if you don't break the contact on both the sides. So now we have this white chalky enamel that I talked about at the gingival margin in your site. There is a bit of unsupported enamel as well as this whole white chalky enamel, and we want to remove it. So what I'm going to do is I'm going to use a round burr. It is well in my sight. And again, if you don't have very good hand control, please protect your adjacent tooth with the help of a band. So very carefully, without nicking the adjacent tooth, what I'm going to do is I am going to okay, so I'm going to remove this white chalky enamel very gently, very slowly, to avoid, number one, over prep here, because I don't want to remove all the enamel. Remember, I need enamel at the gingival floor for good bonding. So that's what I'm doing right now. I'm removing the white chalky enamel, and you will shortly see that I have almost removed all the thing. It's almost clean, and I'm quite happy with what I have right now. I'm not going to remove a little bit of that over there, that can be left. So now we can perhaps move ahead with the restoration of this tooth. And we are just we're halfway through. I have, in this slide you can see, in this picture you can see that I have placed my paludent and replaced my wedge bag. So I took the wedge out, I placed the paludent in the paludent band. This is the one that I mentioned from Quick Matte Flex from Polydentia, made of titanium. It is very flexible. And then I've replaced my wedge bag. And because of its flexibility, it gives excellent contacts. And then I'm going to burnish this band against the adjacent tooth. And the next thing is, of course, all of you know that we're going to place the ring. This is one of the rings that I've placed here is, let's see which ring I have in place. This is the garrison. And you can see the excellent adaptation of this band against the tooth. It is the band, what do you call it? Paludent has wrapped the tooth. Earlier, it was little bit out like this. And if you restore it in this way, you will have not only an open contact, also you will have a flash of composite here and here, which will be very difficult to remove. So this ring not only achieves a good separation of the teeth, as well as it holds the band against the tooth. So let's see what I'm going to do now. I'm going to again burnish it against the adjacent tooth. I have a very good shape of the band, and then I'm going to etch it. Remember, only enamel for 15 seconds, not dentine. So that's what I'm doing, selective etching. That's it. For 15 seconds, and I wash it, I dry it, and now you can probably see the frosty appearance of the etched enamel. And then we are going to turn the yellow filter on, and the yellow filter is the orange filter is on, because we don't want the composite to cure prematurely. So this is the first increment of the bond. I'm going to place it over there, and I'm going to I'll keep agitating it, keep rubbing it on the dentine. Of course, I'm putting it on the enamel as well, but my main emphasis is dentine. So I'm going to look at my clock, and you should have a clock in front of you. You do it for 20 seconds, and then you blow your triple syringe so that the solvent is evaporated, and then you take a fresh bond, apply it again, and keep rubbing your micro brush on the dentine. And then once you do it again, that is blow your air from the triple syringe, make sure there are no ripples, because as long as there are ripples, that means the solvent is there. And if you leave the solvent, what will happen is nano leakage. You will have leakage in your composite. Then cure it, of course. And then this is my first increment. Okay, so let me just go a little bit back. Okay, this is my first increment. I'm placing my bulk flowable in the gingival margin as well as on the axial wall. And this is going to be, this is going to act as a liner, as well as it is going to seal the gingival margin once and for all. So this is on the gingival floor and as well as the axial wall. So I'm using a probe to spread it on the axial wall. As you can see here, I'm using my probe to extend it on the axial wall, and then I'm going to cure it. And all of these steps are the ones that I do in almost every class 2 restoration. So this is a routine for me. So next time what I'm going to do is, I'm going to place a bit of bulk flowable on the buccal and the lingual wall, the Snowplough technique, and then I'm going to use my restorative composite, and I'm going to do a class transition technique in which we convert the class 2 into a class 1. I'm just going to make the wall. So this is what I'm doing. And important thing in this technique is that you just a second, hold on for a second. Yeah. So what you important thing is that you maintain the height of this restoration. That's what I'm going to do right now. So what I'm doing right now is I am aligning the height of this proximal wall according to the adjacent tooth, because this is where you want your marginal ridge to be. If it is higher or lower, lower is adjacent, the opposite tooth will over erupt. And if it is higher, then your whole restoration is going to be proud, and you will spend a lot of time in trimming your composite. So a quick tip is to align your wall, the proximal wall, adjacent according to the height of the adjacent tooth. So this is what I'm doing right now. I'm aligning it according to the adjacent tooth so that it's not too high and it's not too low as well, so that I don't waste a lot of time in polishing and finishing and reducing the bite. And then I cure it, and then I place some more bulk fill flowable as a snowplough technique, and then I place my another increment and I pack it. And when I pack it, with the help of bulk fill flowable, the restorative component will be adapted very properly. So as you can see, I'm giving it a little bit of shape, and let's see if this is my last increment or not. We'll come to know. Then we cure it, and we're going to place a little bit more because it needs a little bit more of the restoration. It's not at the to the right height. And then we're going to place the last increment, and then we'll give it a good shape. This instrument that you can see over here, excuse me, this instrument that you can see over here is known as PKT3, a very handy instrument. And after shaping it, we're going to cure it, a little bit of probe to remove excess as well as give a bit of shape, anatomically contour it, and then cure it. I'm not someone who would, do tints and give a very kind of anatomical shape. I'm just happy with my primary anatomy. I try to be very practical, because after some time there is tooth wear, and all those beautiful shapes are gone. So this is our cured restoration. We are going to now remove this axis from here and be parietal side with the help of again the same red burr, red flame shaped red burr. And you can see the use of this in enhancing the anatomy as well as taking care of any flash of composite that is there on the buccal as well as the palatal margin of the restoration. So this is all removed. So the next thing I'm going to do is I'm going to remove the rubber dam and check my occlusion. And then I'll polish it. That's it. We're done. So you can see I'm just giving a bit of proper shape, enhancing the anatomy a little bit. Rubber dam is removed. Yeah, a little bit of rubber dam gets stuck here and there. Let's check the occlusion. 1 tap, 2 tap, 3 taps, 4 taps. And then you get good occlusion, a little bit of high spots. You can take care of these high spots. And then you can ask the patient to go into lateral excursion as well, like this. So that, because this is a premolar and the patient can have eccentric contacts, especially on the restoration, you don't want any primary contact on the restoration in excursion, because if the restoration will fail, or if you have changed the occlusal scheme of the patient with the help of your restoration, you might want to, take care of it. So this is what it looks like. Now I'm using my white shofu burr to polish it a bit so that it does not discolor because of some sort of remaining uncured resin, because top surface does not cure. Top 20 micrometers is the oxygen inhibited layer. It does not cure, so I'm going to just polish it. So this is the end of this video. I'm going to move back to my presentation. Okay, let's see. Let's share our presentation one more time. Here it is. Okay, so this is the pre-op and this is the post-op, and you can see over here is the fact that we have restored it in such a way that we have kept enamel intact. Otherwise, we could have a situation where most of the enamel was gone if I was to, make it straight like this. And I would have hacked away all the enamel. But I have kept the enamel intact, and this is an internally beveled restoration. And as you could see in my follow-up X-rays, that even up to 7 years, maybe more than that, I have already told you that even those radiographs are old. The restorations stay there. If you do it this way in a methodological way, use a rubber dam, use a proper bonding technique, and use a good material, the restorations don't fall off. So this is the next case, which we are not going to show because it's already 10 o'clock. I'm going to end my presentation here so that we can move on to the question and answer session, because this was another video. We don't have time for this. So in the end, what you need to have is a systematic approach, starting from diagnosis to what you do on the patient, like have a good isolation, and then have a proper technique of caries removal, starting from the high speed to slow speed, and then the excavator, and then using a correct bonding technique, and then using proper class 2 matrices, which can help you get a good contact. And then, all those points written over here, like the systematic approach, a binding radiograph to diagnose the level of your restoration, the lesion, and then, have a self-critique. Always take your radiographs and critique yourself in the radiograph, and then the armamentarium and the bonding durability. Thank you very much, everybody, for your patience. And this is a picture of a young boy who's trying to eat the cake, and this is what usually sometimes happens when we try to restore teeth, but we don't know how to do it, and we end up messing up. Thank you very much. Thank you very much for your patience. And I also have a YouTube channel where I post my vlogs from time to time. If you can, please scan this QR code, and this will take you to my YouTube channel, which is at the rate Arshad Hassan, and you can see all the vlogs and get updates about the newly added vlogs. Thank you very much.
Thank you so much, sir. Dr. Uzma, for a word of thanks, Dr. Uzma is here. Please, Dr. Uzma.
जी अस्सलाम वालेकुम एवरीवन and Assalamu alaikum Dr. Arshad. First of all, I would like to thanks Dr. Arshad for taking out his valuable time on the Sunday especially, जो कि सबका आई होप के बिजी डे होता है. और थैंक यू सो मच फॉर गिविंग इन सच इंफॉर्मेटिव presentation, sir, and it was more needed because the clinical things जो कि हमारे जो न्यू डेंटिस्ट हैं या डॉक्टर्स हैं, पर्टिकुलरली वो जो मैं भी देखती हूँ क्लिनिकली, जब वो आते हैं क्लिनिक्स पे या उसमें, तो बेसिक्स जो हैं, बेसिकली हमारी जो बेसिक्स हैं वो आई थिंक स्ट्रॉन्ग होनी चाहिए. और डॉक्टर अरशद तो माशाल्लाह ही इज़ माशाल्लाह आपकी जो फील्ड है सर, और आपकी जो स्किल्स हैं, नो डाउट बहुत ही ज़बरदस्त हैं. और हमेशा डॉक्टर अरशद की सबसे अच्छी बात जो मुझे लगती है कि सर हमेशा जो है इज़ ऑलवेज कीन टू टीच एंड, और कभी मना नहीं करते. और आज भी जो वेबिनार हमारा है पीडीए कराची का, थैंक यू सो मच सर फॉर ज्वाइनिंग अस एंड गिविंग सच अ और क्लिनिकल टिप्स जो आपने हमें अभी जो बताई हैं, उसमें मेरे ख्याल में जितने पार्टिसिपेंट्स हैं उसमें जूनियर्स भी होंगे और सीनियर्स भी होंगे, सबने बहुत कुछ सीखा होगा सर से. और जो बेसिक्स हैं वो हम लोग जो है नेसेसिटीज़ जो हैं उनको हम लोग हैंडल नहीं कर पाते. कंपोजिट्स की जो सबसे बड़ी बात हुई है उसकी रिटेंशन है, मार्जिनल लीकेज है, जो कि बेसिक चीज़ें हैं जो कि हमें क्लिनिकल प्रैक्टिस में डे टू डे जो हम लोग काम करते हैं तो उसके अंदर फेस करनी पड़ती हैं. तो once again thank you so much sir for your time and giving a nice presentation, and thank you all the participants आप लोगों का भी बहुत शुक्रिया, सबका बहुत ज़्यादा इंटरेस्ट देखते हुए, और सारा दे आर वेरी कीन. हमारा अब नेक्स्ट वेबिनार भी है with Dr. Irfan Kamaruddin. It would be most likely on next Sunday. और उसके बाद डॉक्टर समीर कुरैशी का भी है, तो होपफुली आप सब ज्वाइन करेंगे. उसके अंदर भी जो बेसिक्स है ऑफ डेंटिस्ट्री है, जो क्लिनिकल प्रैक्टिस में यूजुअली हम फेस करते हैं, तो होपफुली इट वुड बी बेनिफिशियल एज वेल. थैंक यू सो मच. थैंक यू एवरीवन.
Okay, thank you so much, Dr. Uzma. Let's take some question answers from the audience side. Sir, the first question which was there is how should an open contact after filling be managed? By removing the restoration or by adding more composite?
Okay, a quick way and easy way to do this is if the open contact is too big, then you don't need to do anything else other than just placing your band again in position. And if the surface has not been contaminated with saliva, so let's say you have a rubber dam on, even if you don't have a rubber dam on, which is not good, you should have a rubber dam on. So you removed your band and you immediately saw that the contact is open. So what you can do is you can place your band back and add some flowable composite. And that flowable composite can easily be placed if you just keep your band uh, uh, held against the adjacent tooth with the help of either a probe, because I'm sure the gap is not big enough to put a burnisher or any larger instrument. So what you can do is just put a probe in that gap in the band, and then flow some flowable composite and light cure it. In this way, that small gap can be closed. And if that gap is not too big for you to place a probe inside, so what you can do is you can probably use perhaps what you can do is you can remove a small bit of restoration, make a small box, and then redo it, just that box. Because what happens is when you have a freshly cured composite, an additional composite can be very easily bonded to it without doing anything else. But there is one condition, that it should not become contaminated with saliva or blood. If it has been contaminated with saliva or blood, then you will have to at least rebond it. So this is how you take care of an open contact.
Okay, sir. Our next question is, what's your take on the use of spoon excavator?
Spoon excavator for dental caries remover, excellent instrument. You need it because you need to have certain tactile sensation when you are removing caries. Because if you are not using it and you're only relying on your high speed or slow speed, you may not be removing either. You may be either removing too much of sound dentine, or perhaps you may not be able to remove all the caries lesion. So you need to have certain tactile sensation, and then a sharp excavator is and you call what do you say, it is important and an essential part of your armamentarium. And as you could see in my video, uh, I used it. There are three things that you should use. First, high speed to clear the dentino-enamel junction of caries lesion, that will give you the outline form. Then use a slow speed to remove dentinal caries, and then use an excavator to further remove the remaining caries. Ji sir, next question.
Sir, moving to the third question. The question is why the restoration is dislodged after proper isolation and proper bonding.
Okay, it is not possible for a restoration to be dislodged if your rubber dam was not leaking. Now that's the problem, you know. The problem is that if you place a rubber dam and if you are unable to see a leak or detect a leak, how will you know that your isolation is 100% correct? You know what happens? There are micro leakages, very tiny leakages in the rubber dam. And without magnification, you cannot detect those leakages in your rubber dam. The rubber dam especially leaks from two places. One, from the retainer tooth, where your uh, your rubber dam clamp is there on that retainer tooth. Around it, you need to place some some liquid dam and light cure it so that does not your rubber dam does not leak from there. And the other place your rubber dam is going to leak is from the gingival margin, because at times the rubber dam is not properly adapted to it, and you have not placed a wedge probably perhaps over there, or if even if you have placed a wedge, the rubber dam is still leaking. So you need to place the liquid dam after the placement of the palodent, your sectional matrix, and your ring and everything. And then if you can see the leakage, there's the problem. If you cannot see the leakage, how will you know it's leaking? Because it's impossible for composite to be dislodged from a tooth that has been A, properly isolated, B, properly bonded. So the problem is with your isolation. Next, please.
Okay, sir. Next question is, how can we ensure a smooth, well-sealed gingival margin in subgingival boxes?
Can you repeat the question?
How can we ensure a smooth, well-sealed gingival margin in subgingival box?
Okay, so you don't need a smooth, flat floor. Please remove this concept from your mind, because the smooth flat floor is a requirement of an amalgam restoration. One of the, the retention and what do you call it? Uh, one of the features that you require for amalgam is it's the flatness of the gingival floor. But with composite, the composite, the gingival floor of composite will retain or regain the shape of the carious removal. After the carious removal, whatever shape is there, just accept it as such. You don't need to have a very smooth floor anywhere for composites.
Okay, sir. Our next question is, how can we overcome from overhanging margins?
Simple, use a wedge. And important thing is that once you have placed your fractional matrix or your circumferential matrix, and they have placed a proper thickness wedge, then just see that with the help of a probe if that band is feeling in the proximal area or not. If not, it's open. Of course, you're going to have an overhang. The importance of the thickness of the wedge is too much. You cannot overemphasize the proper wedge. And if you're using a wide wedge, it is going to be tall as well. So you need to remove the top part, because if you use a very wide wedge, if there is, for example, a wide open contact, so what is going to happen is that you're going to have a very small contact area, because that top part of the wedge will be protruding too much towards the contact area. So just if you have a big wedge, what you want to do is you need to remove the top part so that the wedge is big in thickness but not in height.
Okay, sir. Our next question is, what are the most common causes of failures at the gingival margin of composite class 2 restorations? And what are the effective clinical techniques to prevent this?
The most common reason for the failure of a class 2 in the gingival box is recurrent caries. And recurrent caries comes in because of course, overhang margin. Number two, improper bonding technique when you have caused the denaturation of collagen. And number three, if there is no enamel over there. And at the same time, if your technique is not good as with the bonding, so you'll have an open contact after some time and recurrent caries over there. And of course, if you have not removed caries properly, that can also lead to failure. And last but not the least, in very large restoration, and this has been shown in the literature, that if you use a lot of sandwich technique, that will also fail, because under the occlusal load, the GIC or RNGIC is going to crack or break, and your restoration will fail. So don't use the sandwich technique a lot.
The next question is, if caries extended gingivally, how can we restore it?
With the help of our DME bands. If the caries is too much subgingival, for example, of course, the restorability is questionable, but we can use a two-step technique in which first we use a DME band to elevate the margin above the gingival margin and then restore it normally.
The next question is, if you are considering the patient role in long-term outcome, what are the most essential post-operative instruction we should give to ensure durability and aesthetics of class 2 composite filling?
Good oral hygiene and all the common sense things that one can think of that can cause caries. If a patient is, you need to look at the patient as a whole. You need to assess the caries risk of that patient. So, for example, if a patient is, let's say, a moderate caries risk patient, you'll just tell him to, come for regular checkups and just have a good brushing technique, and uh, just have just reduce his consumption of the sugary stuff, the high carbohydrate stuff. He should avoid, reduce the amount of refined carbohydrate. But for a high risk patient, in addition to all of this, you need to ask that patient to come back at least after 3 months, so that at the time of restoration, you should do a fluoride varnish and repeat it after 3 months. Again, take his bite radiographs to see if your restoration is intact and there are no new lesions, and then repeat it after another 3 months. That is a total of 6 months, and then after that 6 monthly recall. So you have to divide your patients into three groups: severe caries risk, high caries risk, moderate caries risk, and low caries risk, and you have to treat them accordingly.
Sir, our next question is, what are your tips for avoiding marginal leakage and marginal staining?
I think I've covered it previously in my one of the previous questions, where I told about the you know in fact it was covered in the lecture as well, that you need to keep as much of enamel as possible. You need to keep it intact, and then use the bonding technique that I have told you. You need to know what kind of bond you're using. If you're using a 7th generation bond, or even a 6th generation in which there is a self-etching primer, you don't need to etch dentine at all. And then, of course, use a flowable or bulky flowable composite as the first increment. Just line the whole cavity, the whole dentine, the axial wall and the gingival floor. And that will become, of course, there will become a lining, as well as it will reduce the C factor. So all of these will lead to longevity of restoration. And of course, last but not the least, most important, isolation, rubber dam.
Sir, second last question. Why sometimes patient feel sensitivity after composite restorations?
Because of the degradation of the bond. This is the best question, the best answer I can give you. And you can think of anything that happened during the restoration or afterwards. Anything, you know, anything that can degrade your bond, your lack of proper isolation, your aggressive etching of the dentine, whatever that is there that I've told you in today's lecture, each and everything can cause and will cause bond degradation and subsequent hypersensitivity.
Okay, so one question is how to manage subgingival caries which are beyond cemento-enamel junction.
Already told you, with a DME band, remove it and then put a DME band. Use a two-step technique in which DME band is used first, elevate the margin supragingivally, and then restore the tooth normally.
And the last question, sir, regarding composite class 2 fillings, we often see issues with discoloration over time. And from a practitioner perspective, what is the single most critical factor, be it a patient habit or specific clinical technique, that you have found makes the biggest difference in preventing that long-term staining?
Okay, there is no one answer to it. Studies have shown that those patients, or perhaps composite, can get discolored with the help of very dark colored drinks and food stuff. And the food does affect your restoration, the patient's restoration, but it's not the whole story. If you leave a very rough surface, number one. Number two, if you leave unpolymerized composite on your composite surface, or if you apply some bonding agent thinking that it will give a shine to your composite, all of these are going to cause discoloration, because discoloration is, there are basically two parts of composite. One is the resin and the other is filler. Filler does not discolor. It is the resin part that discolors. So if you leave a lot of uncured resin, because the top surface of the composite is uncured, it is the oxygen inhibited layer, that is the curing of its curing is prevented by the oxygen that is present in the atmosphere. So if you don't remove it during your finishing polishing stage, or if you apply some bonding agent over it, because again that is uncured, unfilled resin, both of these will absorb stain. So this number one, the resin. Number two, a very rough surface, and number three, the some blame can be given to the kind of food stuff that patient consumes that can cause discoloration. And older composites that were using camphor quinone as photoinitiator would discolor and become pale and yellow after curing.
That's all the question answers which we have received. For those who have missed the part of the session, the YouTube live link and the recorded video will be shared to you in our official YouTube channel. And please don't forget to fill the feedback form, which we have just posted in your chat. Your input help us to improve these sessions. And on behalf of PDA Karachi, I sincerely thank you, Professor Dr. Arshad Hassan, for your time and expertise, and all of you for making the second webinar a success. Thank you so much, sir, for giving us time. We are looking forward to seeing you again in our next sessions. Until then, Allah Hafiz, and thank you so much, sir.
My pleasure. Thank you.
Thank you.